Today we are going to try and tackle hypertensive disorders of pregnancy. These are kind of complicated, and what makes them a little bit complicated is that we often diagnose and begin treating hypertensive disorders during the antepartum period, but really the main treatment of them occurs in the interpartum period, which of course is a different class than this one. So we will begin to start understanding hypertensive disorders in this lecture, and you will learn more about that in next semester's course as well. So today we want to look at hypertension. There are 4 types, and we will dig into all 4 of these today: gestational preeclampsia, HELP, and eclampsia, and some of the subsets of those 4 types. So it's kind of a big deal. As you can see, 72,000 women die every year because of eclampsia and severe eclampsia, which is not necessarily the right terminology, but that amounts to about 200 women each day. Hypertensive disorders complicate about 5 to 10% of all of our pregnancies, and we're seeing about a 1% increase in this rate every year since 2000. It is the most common medical complication reported during pregnancy, and the WHO states it's about 14% of death worldwide, which is around 10 to 15% of all the maternal deaths worldwide. The morbidity comes from the ruptured liver, of eclampsia, or abrupting the placenta. What's really concerning about it is that if you are diagnosed with preeclampsia or gestational hypertension, it puts you at future risk for cardiovascular disease, hypertension, and interestingly enough, diabetes. It's second only to hemorrhage as a direct cause of maternal death. 17% of them are adolescents, so just think about that. If you are diagnosed as an adolescent and you're already then put at risk for hypertension, cardiovascular disease, and diabetes, which are significant morbidities for someone in that young stage of age. 76, or almost 77% of them are young, so 21 to 30, to have those comorbidities or risk for those comorbidities, and 81% of them are prima gravidas. So they happen to young prima gravidas. We classify these hypertensions. I talked about those 4 different ways. So we see gestational hypertension, and that is when we see an elevated blood pressure in the first time after 20 weeks. Usually the systolic is greater or equal to 140 with a diastolic greater or equal to 90, and that persists for more than 4 hours but returns to the normal in the postpartum period. The second classification is that preeclampsia or eclampsia, and that may be with or without severe features, and we'll get into how to determine which is which a little bit more here. You also have someone who has chronic hypertension, and that's someone who comes into pregnancy already with hypertension of greater than 140 over 90. So they've had this prior to pregnancy, or you're diagnosing it before 20 weeks of pregnancy, and then it persists after that 12-week mark in the postpartum period. So this is someone who's already hypertensive. And then you can also have someone who's already a chronic hypertension, and then they get preeclampsia or eclampsia on top of that. So those are the 4 categories of hypertension in pregnancy. So I hope that all makes sense. So gestational hypertension, let's look at this one first. So the big differences with gestational hypertension as opposed to the other types is that we never see proteinuria. They never spill protein. Their kidney functions remain normal. And it completely resolves by 12 weeks after delivery. However, almost half of these women will develop preeclampsia, especially if they develop gestational hypertension prior to 30 weeks gestation. So it's fairly significant, and it's taken very seriously. We will manage it fairly differently, I shouldn't say fairly, but differently depending on your practice site. But the number one thing you need to do is be continually looking to rule out that preeclampsia. because almost half of them will be looking to develop that. So they'll be seen once or twice weekly for antenatal testing, blood pressure monitoring first. And then everybody across the board, and this is an ACOG recommendation, does recommend that they are delivered at 37, no more than 38 weeks, because the cure is getting rid of the placenta. Well, that sounded terrible, but the cure is delivering the placenta. In my practice, we see these once we've made the diagnosis, especially after 30 weeks. We are seeing them weekly for antenatal testing, so we're doing biophysical profiles and NSTs weekly, and then we're doing serial growth ultrasounds every 4 weeks, and we're seeing them weekly for blood pressure checks, and then we're delivering them at 37 weeks. We just don't mess around with this. We want to make sure that these women are carefully and closely monitored. So then, let's look at preeclampsia. I'm going to dig into this one a little bit more significantly. So hang on to your hats. So what are the risk factors? I took this right out of Varney. You also have a reading from ACOG. They just posted their 2019, it's their updated guidelines from 2013, so that is in the course. And their risk factors are slightly different than what Varney has. I would recommend that you are familiar with both, because the guidelines for treating with aspirin is based on the ACOG guidelines. But either way, please know these. So about 2 to 8% of women will experience preeclampsia worldwide. I'm not going to get into the pathophysiology because the con video that's posted will go into that. I thought they explained that really, really well, and I don't really want to get into that too much more. But the risk factors are you'll be at high risk for developing preeclampsia if you have autoimmune disease, if you come into the pregnancy with chronic hypertension, if you have a history of preeclampsia from a previous pregnancy, if you have a multifetal gestation, any type of renal disease, or if you have type 1 or type 2 diabetes. If you have moderate risk, you're at moderate risk for it if you're over the age of 35, if you have a BMI higher than 30, if you have a mom or sister who had preeclampsia in one of their pregnancies, if you're a nulliparity or so prima gravida, or if you have social risk factors, so African American, low socioeconomic status, or you have a personal risk like you yourself were a low birth weight baby or an SGA baby, if you've had poor pregnancy outcomes in previous pregnancies, or there's been a greater than a 10 years between your pregnancies. So the recommendations are that if you have more than one of the high risk recommendations, or you have several of the moderate risk several of the moderate risks, you should be started on low dose aspirin at 12 weeks, ideally by 16 weeks, and you should stay on it until delivery. And that comes right out of that ACOG article that I posted. So what are the signs and symptoms? Elevated blood pressure is going to be our primary one. Proteinuria. Non-dependent edema, though there's some argument around this because a lot of pregnant women get edema and it has nothing to do with their blood pressure. So don't hang your hat on the edema one. Edema is edema. So a non-dependent edema is probably the bigger one. I really especially look if their face is becoming edematous. That is a big one. Facial edema is a big one for me. But edema is not one that I would, like I said, look for. Visual disturbances, so the blood pressure, proteinuria, and visual disturbances are probably the big one. Headache is a big one, epigastric pain, and then end organ injury, where we see things like the elevated hemoglobin and hematocrit, vasospasm, which would lead to that elevated creatinine and liver enzymes, severe vasospasm that would lead to endothelial injury, which is why we get hemolysis and thrombocytopenia. So in this executive summary from ACOG, which they first said in November of 2013 and they confirmed in 2019, they stopped using the terms mild preeclampsia and The recommended terminology was preeclampsia without severe features or preeclampsia with severe features. So that is how we are to refer to it. So proteinuria is not a requirement to diagnose preeclampsia with new onset hypertension. And they eliminated any proteinuria from the diagnosis for severe preeclampsia. So that was a big change, which you probably don't even need to worry about anymore because that's been a few years now since we made that change. It is mandatory to treat severe hypertension if anybody ever shows up with levels of 160 over 110. In fact, I think the guidelines say that if they come in with blood pressures of anything above 160 over 110, we need to initiate treatment within 30 minutes. So ERs have been trained to do this. So it needs to be a rapid treatment. Magnesium sulfate for prophylaxis is indicated, but it does not need for those who are preeclampsia with severe features, but we don't need to do it for like our gestational hypertensions or for people who are without severe features. So that was a change back in the day. And I don't know how many of you are practicing that in your areas, but that is the recommendation. For people who are prior to 34 weeks, that preeclampsia is severe, and they need to be managed at a tertiary care facility that can manage severe features and complications in the neonate. And they do recommend that gestational hypertension and people who have preeclampsia, either with or without severe features, are delivered at 37 weeks. Expectant management is not recommended. And then the postpartum period is a very potentially dangerous time. So even if they initially stabilize out, preeclampsia can return. And in your course next semester, someone will be talking about postpartum preeclampsia. But we also need to be educating them that the symptoms can return, so making sure that they have good education going home to know what to be watching for. And we also need to be talking to them about what those long-term effects, the cardiovascular disease, the hypertension, and the diabetes, because they are at risk for that. I know that we've talked about the California Toolkit for postpartum hemorrhage, but they also have a quality improvement kit for preeclampsia. So I really, really encourage you guys to dive into that and play around on that site. There are so many good patient education teaching. There's rapid response. There's all kinds of just really wonderful tools and resources for you. I'm going to share one thing that I really like is the suspected preeclampsia flowchart on how to diagnose and manage. And it just walks you through quickly what is their blood pressure? Are they pregnant? What labs have you drawn? What should you do next? Are they severe? Do they have gestational hypertension? So it's just a great, quick way to go through what your next step should be. And you have that in your notes, so I won't stay on here too long. But this is just one of the many algorithms that they have for managing gestational hypertension, preeclampsia with and without severe features. They even have a HELP algorithm. So diagnosing criteria for preeclampsia. So first would be a blood pressure of 140, greater than 140 over 90 on more than 2 occasions, 4 hours apart after 20 weeks gestation when they were previously normotensive, or automatically 160 over 110, and proteinuria. They say 300 milligrams in a 24-hour urine collection or a +2 on a dipstick. They don't prefer the dipstick reading. In the absence of proteinuria, then, you're looking for platelets, renal insufficiency, impaired liver function, or pulmonary edema. So the creatinine level, that's the renal insufficiency, we're looking for it to be 1.1 or a doubling in the absence of other symptoms. We're looking for LFTs that are elevated to twice their normal level. And pulmonary edema is basically a new onset of headache that's unresponsive to meds and not accounted for by any other alternative diagnoses. So they don't have they don't need glasses. They have we can't come up with any other no history of migraines. We can't account for it in any other ways. So that's That's what we're looking for. So that is how we would make that diagnosis. So management, if it's mild, or I shouldn't say mild, that's naughty. If it's preeclampsia without severe features, we can co-manage with an MD, but most of these, and that mainly depends on your practice, most of these will be transferred. Our role is mainly going to be to screen and to early identify these patients, and then refer or consult with our MDs, and maybe ongoing assessment of these patients. But if we have a collaborative model of care, then we can collaboratively work with these patients, but the vast majority of these patients are going to be out of the scope of our practice. But just for your information, and I do want you to know this because it is important, management and the recommendations per ACOG is that to remember that any woman with high risk factors or more than one of those moderate risk factors should receive low-dose aspirin starting at 12 weeks until delivery. Delivery at 37 weeks is recommended for women with gestational hypertension or preeclampsia without severe features. And then magnesium sulfate should be used for prevention and treatment of seizures for women with gestational hypertension and preeclampsia with severe features or eclampsia. And antihypertensive meds should be started rapidly for acute onset of severe hypertension. And I took that right out of that article on the recommendations. This is not necessarily going to be anything, especially the magnesium and the antihypertensive meds, that you yourself are going to be ordering. But the aspirin you should know about, because you should be starting that on your women who come to you who have that history as a protective benefit for them. So let's talk about eclampsia and HELP just a little bit. So eclampsia is the occurrence of a new onset grand mal seizure in a woman with preeclampsia. The incidence is 1 in 1,000 deliveries in the U.S. Mortality from eclampsia can range from approximately 1 in the developed world to as high as 15% in the developing world. I'm not going to touch on this too much because this is more of an intrapartum thing. The morbidity with this is abruption of the placenta, and that is like one of the big things that we see with eclampsia. We can see oopsie. Oh, I lost my slide. We treat with the magnesium sulfate as a way of preventing this. And so it is something that we want to work on avoiding, and that is why we are treating and working so hard to identify and diagnose this soon. HELP is what I'm going to talk about next a little bit here. This is a severe and serious form of preeclampsia, and prompt recognition is vital. HELP stands for, it's a lab diagnosis and not a clinical. It stands for hemolysis, that's the H of the red blood cells, elevated liver function tests, low platelet count, and the LP is the low platelet count. So it's a hypertensive crisis. It occurs in about 2 to 12% of those diagnosed with severe preeclampsia. And it's based on a triad of abnormal coagulopathies, liver dysfunction, and thrombocytopenia. Boy, I can't say that today. So the more abnormal the labs, the more severe the HELP syndrome is. And the recommendation actually is if they're 34 weeks or more that we deliver them. That's how significant this disease is. So we see with the hemolysis, we will actually see decreasing hemoglobins. With the elevated liver function tests, we'll see hyperbilirubinemia, we can see jaundice, we'll see those AST and ALTs be significantly elevated. We'll see low platelet counts, and they can actually, this can be associated with DIC. We can also see PTs be changed as well, PT and PTTs be changed. So they might not have manifestations of severe preeclampsia, but we also can see them have like flu-like symptoms, nausea and vomiting, epigastric pain. These women are at high risk for abruptio placenta, acute renal failure, preterm birth. So these can be really sick women really, really quickly. So we want to be watching and monitoring them. Women with severe preeclampsia. Did I skip? I feel like I skipped a slide. Oh, hold on. No, I didn't. Okay. Women who have severe preeclampsia and hepatic involvement may develop hepatic involvement and may develop HELLP syndrome. In one study, HELLP syndrome occurred in approximately 20% of women with severe preeclampsia. As with severe preeclampsia, HELLP syndrome is associated with all kinds of adverse outcomes, which I've said most of these already. So, some clinical pearls. When patients present with vague symptoms like headache, abdominal pain, shortness of breath, generalized swelling, complaints of I don't feel right, take big note of that. Almost all of these women you want to be evaluating for atypical presentations of preeclampsia or severe pressures. I've learned to trust my gut with that. I had a patient once who she had this mild headache, but her blood pressures were always relatively normal, like 130s over 80s, 138 over 88, no swelling, just nothing. She was normal DTRs, everything was fine with her. And finally at about 34 weeks, I said, I'm just going to draw some labs because clinically everything looks fine except you have this very mild headache that you've had for about a week now, and your pressures are fine, but I don't know, I just don't feel right. And her platelets were I think they were 82. And they were in the tank, and her LFTs were through the roof. She was in full-blown HELLP, but no symptoms other than just, I don't feel right, and something's not right with my body. That was the only thing she kept saying, and my head, just this mild headache. That was it. And if I hadn't drawn the labs and hadn't gone with her gut, we would have never known. So sometimes that sensation of I just don't feel right is so important to watch. And she literally bought herself a ticket. We drew labs and she was in the OR within 2 hours, and they delivered her so quickly. When I called my doctor to say her labs are her platelets are 84, he's like, you mean 84,000? I'm like, no 84. He didn't believe me, but it was true. She had to spend some time in the ICU. It was crazy. Some more clinical pearls. All patients with severe preeclampsia, irrespective of their gestational age, needs to be evaluated by your backup. And all patients with severe preterm preeclampsia, they can rapidly progress to severe morbidity and mortality. So you really, really want to be mindful of that and get your collaborating physician involved fast. So the initial labs you're going to draw, you want to get that CBC so you can get your hemoglobin, hematocrit, and platelets. It's so important because you need those platelets. You're going to get an AST, ALT, and LDH for your liver enzymes. You need to get that creatinine, bilirubin, uric acid, glucose. And if they have acute abdominal pain, you can add the ones below. I don't do that so often, but that's the recommendation. Then you also want to make sure for your assessment that you're documenting what is her headache. Does she have one? Does she have visual changes? Does she have epigastric pain? Does she have reflexes? Or if she has reflexes, what are her reflexes? Does she have any clonus? And her blood pressure. You can document edema, but I would more importantly document, has she said is her edema worse, or is it stable? Has it changed any? That would probably be a better documentation since most women have some type of edema. Management, as we've said before, delivery is the only available cure. It's a dynamic, multi-systematic process that progresses at variable rates. It can go really rapidly or it can be a slow process. So we have to weigh all of those risks when deciding between delivery and expectant management, especially in that preterm phase. We know that 37 weeks is what they recommend for delivery. All patients will be either co-managed or transferred depending on their severity. So the management is at 37 weeks, delivery is suggested. Magnesium for seizure prophylaxis. Prior, if reliable, they can be outpatient, and this is if they are a gestational hypertensive. Twice weekly visits with home health in between, if that's available for you. The goal is to identify severe features early. So we want them doing kit counts and identifying symptoms. We're going to be doing labs. They say twice a week here. I think we do them every other week. Fetal stress testing, so BPPs and AFIs, depending on how your clinic wants to set it up. Management for severe preeclampsia with severe symptoms is delivery as soon as the stabilized status, vaginal delivery unless contraindicated, and if it's less than 34 weeks, then they have to be transferred to a tertiary care facility where they would work with MFM, and you can kind of see we do methazone to get them ready. I added in here another thing from the California toolkit. It's kind of had to be stretched between two slides here, so hopefully you can see that in your notes. I just really liked how this worked. So you can go through all the different things that you need to assess. So on the one slide here, it's awareness, headache, vision, where their blood pressure is, where their respirations are, what pain they're having, what their kidneys are doing, and what their liver enzymes are doing. And then if you go on the next phase, it tells you if everything isn't more in the green, you can proceed with normal. But if they start to have a trigger or more than two, this is more nursing related, but you can kind of think for yourself, like you would notify yourself if you needed to order lab tests, consider magnesium sulfate. If they start having more than one red type, it starts telling you what you need to do. So let's go back up here. So if their blood pressure is getting up into this red zone, or if their respirations are lowering because this would be a MAG, if they're having nausea, vomiting, chest pain, the tracing is in a category 3, their urine output is decreasing, their labs are tanking, then it tells you on this, you maybe need to consult neurology, or maybe you need to give labetalol, or it tells you. So it's really, I thought, a really nice slide on a couple slides on things that you can consider doing. So MAG, most of us know this from our nursing days, but it's an anticonvulsant, CNS depressant. It's normal. The side effects are warmth, sweating, flushing, hypotension. But toxicity is something that we need to treat. So they can get hyporeflexive, which is the first sign. And if the respiratory rate drops to less than 12 a minute, or we see oliguria, which is less than 30 mils an hour, or decreased level of consciousness, then we need to treat with calcium gluconate, which is the last blank. We want the therapeutic magnesium level to be 4 to 7, but if they do show any signs of toxicity, we would need to reverse that. So we're finding evidence that we said that they have that future cardiovascular disease in children born to moms with preeclampsia. They also have a risk for future cardiovascular disease and future preeclampsia. So we really need to encourage prevention strategies to reduce their risk, because a lot of our patients continue to see us for their primary care. So we'll want to be mindful of that and carrying that forward. So postpartum management, 33% of seizures will occur in the first 24 to 48 hours after in the postpartum period, So we want to continue the MAG in that first, 24 hours. I keep doing that, 24 hours. Persistent elevated blood pressure should be treated with an antihypertensive, and that might continue for the first 6 weeks postpartum, and that would be co-managed with your ND. Gestational hypertensions, preeclampsia, or superimposed preeclampsia, all of these will be monitored in the hospital for at least 48 hours up to 72 if they're not coming down. And blood pressure will be obsessed for up to 10 days post-delivery or earlier, so they might come in for a blood pressure check like 2 weeks post-delivery if they need to. So it's important that we include those signs or symptoms in the discharge and teach them when to call if they're having any signs, because postpartum preeclampsia can occur or it can come back, so we really want to be careful with that. So that is PIH. I just touched on the other ones. I hope, here are my references, I hope this gives you a good handle on the readings, or at least clarify some things. If you have any questions, please feel free to post questions as always. And that's all for today. Take care, everyone.